Welcome to this Give Me 15 Minutes education program for medical professionals. My name is Jennifer Searfoss, and I am the CEO of the Searfoss Consulting Group. This presentation will address what you need to know about Obamacare, also known as the Affordable Care Act, also known as health insurance exchanges in the DC, Baltimore metropolitan area. It's recorded live on December 11th, 2013. This session, along with others, are available for free through iTunes as a podcast or as a video archive on YouTube. Learn more at jensearfoss.com, including learning about in-depth sessions on the 2014 Medicare final rules. One quick legal note, none of the information contained in this presentation should be construed as legal advice. I encourage you to contact counsel if you have any questions regarding state or federal law that apply to concepts covered in this session. With that, let's get started. And in full disclosure, this is going to run longer than 15 minutes because there is a ton of content to cover. So just as a reminder, what is the timeline for the implementation of Obamacare? And the biggest thing, when we think about Obamacare, again, it's a huge omnibus act, but it's related to the individual mandate and requiring individuals to have health insurance. And so to obtain health insurance is through the health insurance exchanges. So again, just as a reminder, March 23rd, 2010 is when the Affordable Care Act was enacted. Then you have, in August 2010, the first grant was issued to states. Maryland is one of the ones that really stepped forward and said, you know what, we want to get involved. July 11th of 2011, they proposed rules from the Health and Human Services Department. And the deadline for states to submit a plan to run a health insurance exchange, and the acronym we used for that is HIX, not to be confused with HIE, since we already had that for health information exchanges. But for the health insurance exchange was December 14th, 2012. And again, Maryland applied. Virginia did not, and DC, being a federal district, was going to be run by the federal government. So in 2013, so this year, the deadline for states to have a plan for partnership and the actual engagement of it was due on February 15th. Virginia did not step forward. Instead, they said the federal government would run their exchange for Virginia. And open enrollment started October 1, and you have seen all of the media about the problems that not only HealthCare.gov has had, but also we'll talk a little bit about our wonderful Maryland connection and the fact that this health insurance exchange website has been abysmal. So as of January 1st, 2014, the exchanges are live with health insurance coverage. And so that's our big date we're trying to get ready for in 3 weeks. January 1, when new insurance coverage is available, and I, as an individual person with self-insurance, guess what? I'm part of that, and I actually can say I am a proud enrollee as of yesterday. So 2015, this is when the health insurance exchanges are supposed to be financially self-sufficient. There's no grants from the federal government. And then in 2017, right now, states would then have the option to have the health insurance exchange apply to large employer groups. Again, each state would determine what they want to do, but that's the plan for this to move forward. So what I want to say, again, from a physician office perspective and even for other health providers, what I want to say is that honestly, all of these changes are not going to impact your office in a large global way in our region. There's other regions that have been dramatically affected, but really not in the DC metropolitan Baltimore area. Instead, they're going to use the existing railroad tracks, and no new contracts are required. Instead, the health plans that are sponsoring health insurance exchange products are going to access the current contracts that they have with you. I'll get into what that will mean. So there may be new networks and other limited networks that are going to come forward, but right now, again, it's just the same as we've been moving forward, or the same that we've had in 2013. So let's talk a little bit about the products. I'm sure you've heard about our metals. They are bronze, silver, gold, platinum, and then there's a catastrophic coverage for patients under age 30. The way that this works is that the deductible is somewhat tied to the way the coinsurance is set. So what's been standardized is that the coinsurance is going to be 30% for bronze, 20% for silver, 20% for gold, and platinum 10%. Catastrophic is zero coinsurance because, again, it's got a large deductible. The maximum out-of-pocket cost is $62.50, but the annual deductible can change, and each of the different products can have different deductibles. The cost, obviously, that premium is going to change on what the deductible is, and I'll show you some of the examples. But again, keep in mind that these oftentimes are going to have very sizable deductibles related, and again, I really feel that these are high deductible plans that are being offered through the health insurance exchanges, unless you're looking at a platinum plan. So what do we have? We have a mix of the different sponsors for the products. So let's just walk through them. In the DC area, it's a federally hosted exchange. As I mentioned, the federal government, HealthCare.gov, is running that. The individual insurance is being offered through Aetna, CareFirst, Blue Cross Blue Shield, Kaiser Permanente, and United Healthcare. Medicaid is through Amerigroup, MedStar, and Trusted Health Plan. So again, those are the contracts that will be accessed for your Obamacare enrollees. In Maryland, slightly different. CareFirst is using both of their networks, so both for Blue Choice and Blue Cross Blue Shield. There's a product called Evergreen Health, Kaiser Permanente, and United Healthcare, and then a large Medicaid expansion list here. And what I want to note is a number of them only have access in local areas. So for instance, JAI Medical Systems is only in Baltimore. Virginia is a pain because it is actually by county. Again, it's hosted by HealthCare.gov, but by county, and in certain instances where it's a city is acting as a county, for example, Arlington or Alexandria, you have to go in for each of those as well. Anyhow, your sponsors there are Anthem, Blue Cross Blue Shield, Anthem Health Plan of Virginia, so again, both of them. CareFirst, when you're looking at the DC metropolitan area, as you well know, CareFirst and Anthem have a division line on 123 that rings around the district, so that's the dividing line between the two. Kaiser Permanente, really only in the northern part of the state. Innovation Health Insurance, again, northern part, mid-state, and then Optima Health. So those are your big ones. So what are they offering? CareFirst is offering a number of platinum. When you get into the Blue Choice, so again, that HMO kind of model, they've got 3 gold, 3 silver, 3 bronze, and 1 catastrophic. We'll talk a little bit more about that. Evergreen has a number of products there as well. Kaiser, again, one of the things to note about this is that Kaiser has, as you all know, a very different model for their physicians, but they're offering 2 gold, 3 silver, 3 bronze, and 1 catastrophic for the way that they're set up. United Healthcare, I'm going to spike out United Healthcare. The licensed entity for United Healthcare is All Savers Insurance Company. I'm going to come back to that because it's a really big deal. And then you have Blue Cross Blue Shield multi-state, where, again, it's going to be able to transfer over. So for Maryland, again, these are the products that are in Maryland. There's 24 plans with statewide coverage, 8 PPOs, 9 point of service, 20 HMO products, and 8 EPO. So it's a very broad offering, and some of these are actually quite expensive, over the $400 for, at least when I was pricing them out for me, $400 a month. Just to give you, again, some feelings for what the premium ranges are, this is for Montgomery and Prince George's County only as a sample. This was some analysis that was done by the state, so if you're interested, there's a number of Maryland reports that are available to you. But again, for a young patient, age 20, single, non-smoker, the premium would range for a bronze product all the way from $68, that would be your cheapest, to $150. And then you start staggering, again, depending on where that deductible is and what they want included. Your silver coverage, gold, and platinum, the highest for a 20-year-old non-smoker, would be $181 a month. You start looking at older folks, so age 64, again, non-smoker, you're going to start all the way from $320 a month to $853 for a platinum. And then when you start looking at the families, again, this is where it's going to start doubling up on the coverage, and so you see the numbers begin to double. Again, I can tell you for myself, I'm in my mid-30s, and the rates that I was looking at were anywhere from $150 to about $400. I'm also in Talbot County, so that also helped me. So what is Care First offering? So again, they're bordering over into DC and Virginia. The way that they offer these products is that they've got a Blue Cross Blue Shield Preferred, and the $1,500 or $500 is what the deductible is. And so that's a big deal on which band they fit into. So a $1,500 annual deductible is a silver plan versus a $500 deductible, which is gold. Then you have the Blue Choices for the larger deductibles. They do have an HSA option available. So again, always Blue Choice, and these are going to be your HMO products, going all the way from, looks like here, of a $6,000 annual deductible to a $0, which is going to be your gold. But again, that is an HMO. There's two point-of-service products, bronze and silver, again, different set deductibles. The catastrophic, they're calling Blue Choice Young Adult. Again, that's a full deductible of $6,350. The big thing on that one, obviously, is that they are accessing the Blue Cross Blue Shield / Care First fee schedule. Again, other products that they've got out there, the Platinums are going to be $0 deductible, but again, those are going to be your, we've been calling Cadillac plans. It's going to be more expensive. So Maryland United Healthcare, as I mentioned, they are calling this All Savers Insurance Company. I have been reassured by United Healthcare that their healthcare ID cards are going to have the flying U up in the left-hand corner. And the only thing really that's going to look different on their ID cards is that the health insurance product is going to say All Savers, and it's going to be in the bottom right-hand corner underneath the prescription box, if you're familiar with their ID card. So something to know about, your patients may say that they have All Savers insurance rather than they say, I have United Healthcare. It's a great education opportunity. They are, again, accessing their normal network that they have, which in this state is licensed as an EPO network. And they are offering a number of items out here. Again, they've got some HSA products. They do have the different Silver A and Silver B is really set up on what type of cost sharing the patient wants to have on different types of services. So it really comes down to people shopping for their insurance and, of course, understanding it, which we all know they don't. So let's talk about Anthem and HealthKeepers. Again, this is an HMO product. They do have child dental as either an option or bundled, depending on how they want this set up. The Silver Direct Access is a multi-state plan, so again, where it can cross over state borders, and they do have a catastrophic offering. One of the more interesting ones was the Innovation Health Insurance Company. This is an Aetna and Inova venture, so you know about that one. But they have a pediatric dental, which is included on a number of plans. They have a couple of them which says MO on them. It just throwing me off. And it's where bariatric surgery is covered. So again, people can decide whether or not they want bariatric surgery covered. It's, again, very interesting on the way that they've set this up. It's, again, different than they've done in the past. One of the notable things, too, and I want to spike this out, is prescription drugs are included in the deductible. So people are going to be able to hit them a lot faster than they have in the past. Optima, again, the way that they have it set up is that they have a number of different equity products or bronze plans, which are at different deductibles, going by about a $500 or $250, differential on these. The Foresight is a silver and gold plan, and then they have the catastrophic. Again, bariatric surgery is one that they can have carved out or not. So where are we? And again, this is a live webcast that is recorded on December 11th. So I have the report that came out. Secretary Sebelius was actually talking while talking to Congress and giving this report while I was writing these slides. So let me give you the latest. From the District of Columbia, first thing is that the guy who was in charge of the exchange was fired. And so there's a new interim and acting insurance commissioner who's been overseeing this, and that may have a lot to do with the fact that for the report that just came out, data is not available. But what we do have from the November 15th report is that less than 10 people, and again, it's been rumored that 5 or 7, have actually registered and paid their premiums. When Congress started pressing and said, what's going on, we found out 2 people were enrolled in a Care First plan and 3 were enrolled in a Kaiser plan, but we have no other data, and when other health plans were asked, they were told that nobody had enrolled. Other DC staff, the actual folks in the insurance department, are saying that there are 321 DC residents and 426 small businesses had selected a plan. But again, this is one of the things that they've talked about through HealthCare.gov, is that it's one thing for the paperwork to have been filled out. It is another thing for the actual payment or premium to have occurred. So that's one of the big issues, is it's not enough just for them to have filled out the paperwork. The premium for January 1 needs to have been paid, and that's not happening yet. So let me talk about Maryland. This has been a headache and a half. So Maryland's hosting its own health insurance exchange and has its own web portal, which is fine and good. The problem is that the website does not work. And my sister, who is a health insurance broker, she and I, after I had been spending hours and hours and hours trying to make the thing work, we decided over Thanksgiving to sit down and enroll me. We thought, great idea. After it kicked us out 6 different times at 6 different stages of the enrollment process, we both gave up. And I can say that on December 10th, I tried again to get into the connection, and it didn't work, so I just went directly to the health insurer and enrolled through their web portal. And that's really, I think, what people are having to do. Either they're calling in or they're going to the insurance company directly. One of the biggest issues, too, is going back to what's been known about HealthCare.gov, is that payment has been a major problem. So right now, the way things are set up is the exchange board decided to let insurance handle payments directly, and they delayed opening the small business marketplace until April 2014. So the numbers from the Sibelius December 11th report from the federal government was that there's over 20,000, almost 21,000 completed applications for coverage through the health insurance exchange. 1604 is the number of plans that, or individuals that were eligible for a plan, which is great. And then an additional 5861 were eligible for a plan with financial assistance. Again, wonderful and good. 13,000 were eligible for a Medicaid plan. Here's where we run into a problem. Less than 4,000 of those 20,000 have selected and paid for their plan. So we may have a number of folks that on January 1st think that they have coverage, but they haven't paid for it. And so you run into a problem in the office with people who think that they have coverage and they'll have printed out their application, but they don't have a health insurance card, and it's a problem. So again, patient engagement and discussions beforehand. So we'll talk a little bit more about that. The only good news I have for you is that this is up from the total of 1,700 from the November 15th report, which is great. The demographics that we know is that it's mostly women and middle age, so I guess I fit into that, so that's lovely. Also, 2/3 that were enrolled were between ages 35 and 64, 21% were 25 to 34, 13% were 24 or younger, so not a lot of folks enrolling in catastrophic coverage, to be honest, with a very slight penalty on individual mandate. I think a number of the young people who enrolled in this is not going to be great, at least this next year for 2014. As that individual mandate penalty increases, that likely is going to increase as well. Majority of folks are enrolling in bronze and silver plans, which means that they are enrolling in high deductible plans. So let's talk a little bit about Virginia. Previously, we didn't really have a lot of information. We only knew that there was about 1,000 folks that had signed up, a lot of visitors. What we do know now is that there's been 90,000 completed applications. 67,000, almost 68,000 have been eligible for a plan, with an additional 22,000 eligible for a plan with financial assistance. Very few that are using HealthCare.gov are eligible for Medicaid, and that has to do with the fact that the state did not expand into the gray area Medicaid coverage. But going back to this payment thing, less than 5,000 people have selected a plan and paid for it. So it becomes this whole issue of paperwork sitting there and premium is not being paid. We're going to hope that in the next several days this really gets ironed out. The last thing I want to highlight for the DC metro area is that CareFirst is canceling insurance, and I've seen these letters personally, so I can tell you it's going on. So Blue Cross Blue Shield has almost 200,000 individuals under 65 that they cover in the DC, Baltimore metropolitan area, so all of Maryland, DC, and the northern parts of Virginia. 76,000 individuals are going to be dropped from insurance, and they've received 2 letters so far. The first one told them of what was going on. The second one reminded them that they needed to take action by December 16th. That's the big date, December 16th. What basically they're stipulating is that the insurance policies that the individuals enrolled in are not compliant with the Affordable Care Act mandates, specifically on out-of-pocket maximums, also on the type of insurance that's being offered, meaning that does it cover preventative care, that type of thing. Also on the co-insurance, so it may have higher than the federally mandated, say 20 or 30% that's now mandated under the Affordable Care Act. So because they don't fit into a bronze or silver or gold, usually bronze or silver, category, they're just canceling the products. Patients have 3 options. They can choose to enroll in an Affordable Care Act plan. They could choose to cancel coverage, or they could choose to have a 1-year flexible time where they continue their current insurance for 1 year for all of 2014, but in 2015 they would have to have a new insurance product. So that's where this stands right now. Again, if you're getting calls, that's what it's about with CareFirst canceling their insurance. So I'm going to cover a little bit more about who the newly insured are. I know we are way over time, but again, this is really important. This is some really great data that came from PricewaterhouseCoopers. I highly recommend you check out this study. It's really interesting. We know that patients that are coming in now are going to be less likely to be white. They are less likely to have excellent, good, or very good health status. They are more likely to be single than the currently insured. They are less likely to speak English. They are less likely to have a college degree because, again, they don't have to have the insurance based on employment. So there's a new population coming in that do not have college education. And their employment status may not be full-time anymore because, again, that was a requirement before for employer-based insurance that you needed to be full-time. At least that's how the majority of employers were doing it. And so they're less likely to be employed full-time. So what does this mean? It means that there's a whole new population that has no idea what's going on with health insurance, and there's a pent-up demand. So we looked at what Oregon and the Medicaid program expansion did, and this is like the best indication we have for what January 1 is going to look like. We know that there, again, was a pent-up demand, and so there was an increased likelihood for outpatient care, for prescription drugs, preventative services, and honestly being even admitted to a hospital. Patients were like, woohoo, we have health insurance, we're going to use it, and they did. So what happened because of that pent-up demand was that there was an undetected disease that was now picked up, and the folks were then front-ending their benefits, meaning that as of January 1, they've got health insurance, they paid for it, they had to pay for premium to get enrolled, so we're going to use our insurance in January or February. But let's say, oh, I don't know, sometime in May, they stop paying their premium. Again, it's one of those, are they going to go back for health insurance? We don't know. Are they going to go for health services? We don't know. I'm going to talk briefly about the 90-day period. We also know that language, culture, and health literacy are some really big new areas that are going to be applicable for these patients. So we know a couple things. One, preventative care screening is going to find disease. Now, notably, under Obamacare, preventative care is a $0 coinsurance. It does not apply to the deductible. It is going to be something that is just paid for by the insurance company. So my big coding note, please code preventative services as being preventive services. Because if you code it as a 99213, the coinsurance and deductible will apply. If you code it using the appropriate preventative service codes, guess what? It now will be covered under preventive service. So make sure you're using the appropriate ICD-9 codes as well as CPT and HCPCS. Prescription drug benefits. These folks may not have had access to prescription drug benefits and the fee schedules that were lower. They're going to start using that. They're going to start looking at elective surgery because, again, they don't have to pay for it full freight, and they also are going to be staying in the hospital. But they have no idea what health insurance is. I've done a lot of education around this, and usually I try to compare it to car insurance because most people have car insurance. And like car insurance, they have to pay for it. It's amazing how many people thought that they now had free health care coverage under Obamacare. Crazy, but most people do think that. So again, a lot of patient education opportunity here. Managed care, this whole concept of being in a network is new to them. They don't know what these mean. Again, the health plans do have, if they're non-HMO, they will have an out-of-network benefit, but they have higher deductibles on the out-of-network benefits, just like normal. Again, usually it's going to be 2 to 3 times what the in-network deductible would be. So in-network referrals, co-insurance and out-of-pocket expenses, you know, the patient pushback of, oh my gosh, I have no idea what you're talking about. I paid for my insurance. I don't have to pay anything out of pocket. Again, just like with car insurance, you break your windshield, you have a $250 deductible, and you have to pay that first. Love using the car insurance. And then again, the high deductible products, this is a big area where people should learn about the HRA, HSA, learn more about it. Really the HSA for the majority of individual products, that's the only thing that's offered since there is no employer to sponsor an HRA. So having that conversation about cost is going to be the hard part of January 1 and to go forward. But that needs to start. And figuring out how your office wants to address transparency in pricing is also a very big issue. Smartphones, big deal. This demographic, people love doing text, not web engagement, but everybody has a phone that can do texting. There's been a number of studies on it, so it's going to be really interesting. And transportation is going to be a bigger issue for, again, this demographic that's coming in than it has been in the past. So figuring out your community resources for transportation will also be a big opportunity. I want to briefly touch on language. I'm sure you're familiar with the limited English proficiency requirements that are triggered from Medicare Part A or Medicaid dollars that your offices would receive. Other states like California have their own requirements. But what we do know is that the majority of folks that are coming in, and it's going to be about 63% of non-English primary speaking folks are going to be Spanish. And they're also really young, and that's something that's really big. So the top 2 are Spanish and Mandarin. And so again, knowing that of your demographic, knowing about your patient population, knowing what the community need for language support is going to be come January 1, it's a really big deal. It is 9% of the non-elderly population right now on a national basis. So again, figure out what resources you have available in the community for support. Other things to think about is health literacy. It's not so much that folks won't be speaking English. It's also, too, that the medical terms are really, really difficult. I tease that it's actually worse than legalese. It's very prohibitive, and in many ways, patients don't understand their engagement. Latest studies that we know is that only 12% of the U.S. population is considered proficient in the health literacy, and I'll talk a little more about that. And then again, the cost of low health literacy is significant. So engaging folks in a way that they understand what's expected of them and what they need to do to be compliant is a really big deal. So stepping up on my fantastic just soapbox, if you will, there is an American College of Physicians video I highly recommend. I've got a URL on the slide in front of you. It gets into some scenarios where real patients are asked to explain what's going on. And the slide photo that I've taken here is for a mother of 2, and she was unable to read the over-the-counter fever medication that she was giving her children, and she'd been over-medicating them for years. She also was unable to read the billing and consent paperwork, which was set at and so she had a 3rd grade reading level. And normally, again, I try to target a 4th or 5th grade reading level, but still that's really hard to do on consent paperwork. There was another male patient, who couldn't read his prescription at all, and he didn't understand that his blood pressure was actually too high, and that's why he was taking it. He also noted that when he gets a lot of paperwork, he feels like he's in another country, and oftentimes he just wanted to leave. So if there was too much paperwork, he would actually not seek health services. Another elderly female patient, she doesn't read the warning labels at all, and one of them said, "Don't drive," and she had just driven to be a part of this interview. So again, understanding the needs of patients and ways that you can help your office to get patients to be more engaged. One, it's going to help the overall aspect. Two, it's going to dovetail into a lot of the quality reporting and other engagement programs that are going on. And third, it's also going to decrease the number of calls your office gets. So what do you want to look at? Communication of insurance basics using very normalized words and not terms of art. Explaining what is a preventative or treatment visit. Outlining what charges are and doing take-home copies. Again, using terms that people understand and use in their daily lives. And then also icons, really, really big deal. Icons often, again, for people that struggle with reading, icons are very, very helpful. The other thing, too, is teach-back method. As a former professor and 8th grade English teacher, I love doing the teach-back method, which is, I just told you something, what did I tell you? You tell me what I just told you. It's a different way of practicing medicine, but it's been shown to really, really engage. A couple other things to think about, no-shows. Higher incidence of no-shows is expected with this new population come January 1st. So 40%, up to 40% are going to be no-shows for Obamacare insurance folks. People that are new to insurance don't understand the cost of not showing up to appointments. So doing reminders, again, thinking about text. Text is a really big deal. Could you text folks about their upcoming appointments? Doing live calls, which again, majority of professionally run practices do. Think about postcards in instances where it's difficult to reach them. Think about transportation and having route information with a reminder of how to get to the office. Also, identify your repeat offenders and schedule them accordingly. Just change the way that you engage with them. Really a big fan of tracking reasons for no-shows now, meaning that you follow up with them. What can you do to get people to show up? And there's a number of codes actually you can use in your practice management system to begin to really get an idea about why they're not coming. Make sure that you have a written policy for patients on no-shows so you can charge them. Have them sign the policy on their first visit. There's a couple states that prohibit no-show fees, especially for Medicaid patients, so be aware for that. And then also make sure that it's a reasonable fee and it applies to everybody in the office and not just, again, certain insurance or an age demographic. So things we know about from the past, Medicare Advantage, Medicaid, and high deductibles. One is that people had no idea what network was going to be. They also had no idea that what the difference is on variations from that 80-20 coinsurance is. So again, from Medicare Advantage, we saw that patients didn't quite understand that variation. The nice thing about Obamacare is it does standardize what it is, but again, patients don't know what a coinsurance or copay versus deductible is. I have no idea, so that really needs to be done. Medicaid, expect churn on product enrollment. Remember, they can change at the beginning of every month. And high deductible plans, financial flexibility with large sums. If they are expected to pay a $5,000 out-of-pocket for a procedure that's performed, is it possible that your office can set up a payment schedule for them? A couple other last items to cover. Please, 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 please do eligibility and benefit verification at the time of service, and require photo identification at each visit. This is a really big deal because, again, as people are out there, they may be swapping insurance. As we've seen over the last several years, this is really, really, really increased. So something to think about. Quick note on non-payment of premiums. So there's a 90-day period where patients will be given a grace period until they're kicked off of the insurance. The difficulty, of course, is that after the first 30-day period, the medical practice will be held liable for it. How is this going to show up on the insurance's web portal or the call center information regarding eligibility? We don't have a lot of detail yet, so it's going to be very interesting to see how this goes. We're hoping that it will say premium not paid. Yes, impossible coverage, premium not paid, but we haven't gotten a lot of detail on that. So stay tuned on what's going to be showing up on the web portals, and as soon as I learn, I'll be posting it on my website. And just the last thing that I wanted to go over is considerations, or honestly it's homework for your practice. Just go back and look at your policies, financial policies, no-show policies, payment flexibility. Do you have discounts for same-day payment? Certain things like that, especially when it's a large deductible. Of course, you do run into contractual obligations, so make sure that you walk that line. Review your paperwork. Is it simple? Does it meet language requirements? Is it something that someone who has a third grade reading level would understand? What's the patient intake process? Remember that patient who said if there was too much paperwork, he'd just leave? What is a way? What is your intake, and how can you change it so that patients are not overwhelmed when they walk into your office? Track your no-shows. Make sure you have interpreter access. Look at your community resources. And then also talk to your clinicians about how they are going to approach patients, and possibly in a different way come January 1st because of this new patient population. The last one is just educate and engage your staff. This is going to be a great learning opportunity. And again, there's going to be a lot of ideas that come out of it. So you have just had the most incredible 15 minutes that has turned into 41 minutes presentation on what to expect in the Baltimore-DC metropolitan area about the expansion of health insurance for Medicaid, and then also the new health insurance exchanges through HealthCare.gov and the Medicare, the Maryland connector. So I hope that you've enjoyed this presentation. For those of you that are listening to the podcast or watching the video archive, please remember to rate this recording in iTunes or YouTube. To receive notices about upcoming Give Me 15-minute programs or other educational sessions, please sign up on jensurfoss.com. Thank you for joining me for this educational program. This concludes the presentation.